Good afternoon, and thanks for the introduction. Thanks for inviting me. As mentioned, yes, my name is Miroslav Končar, and I'm probably one of the few non-French speakers in the room. Apologies for that. But a great job you guys are doing there, and appreciate the translations. It's my first time here, and I hope that my topic will be, I think, less complex. I'll try to make it so, at least. I'm fascinated by what the previous speakers have spoke about, but I think what I'm going to talk to you about is not necessarily big data. It's more about the foundations of everything what we are talking about today, because I think when you go through all these presentations today or in the days before, I think there's one underpinning foundation in all these ideas and innovation that we talk about, and that's data, right? The data about ourselves, about our bodies, about our health, about our sickness perhaps. And how do we make sure that everything that we talked about today becomes part of the innovation framework? So whatever application we are trying to build gets fueled by the data. And if that innovation gets to be very successful or fails, that we at least don't, whatever happens, we don't lose the sight of the data. So we can transfer it to another environment, another application, if you will. So, as the slide says, my name is Miroslav Končar. I represent the company called Marant. We are out of Slovenia, about 150 people, but we operate internationally. So we work through a number of communities, a number of partners, and a number of economies, from Brazil across Europe all the way down to Philippines. So what I'll share with you is a more international experience than just 2 million people country out of Central Europe. I also carry multiple hats myself, so next to business development, I'm associate professor of biomedical informatics. I chair some of the standardization committees in health IT, so I'm not going to pitch any products today. I'm just going to talk about experience and what is our idea in terms of making some of these foundations, let's say, possible. So the outline is hopefully simple. So why is innovation in health IT is important? Everything we talked about today, why is it important from our own individual perspectives, I would say. But why is it also difficult, right? I think there's this word pilotitis. You probably heard of it. We've been talking about so many innovations in health IT for decades now. But I mean, everybody I think in this room probably has a mobile phone, a smartphone with a mobile banking app. I've seen people 10, 15 years ago which did not even know where their physical bank is. But I'm pretty sure that very few of you, if any, are using some mobile health app which is connecting you with your doctor wherever she or he may be. So why is it difficult? Why has it been lagging behind, perhaps compared to other industries? And a small ingredient or a recipe to a success, that's what I'm going to focus on, show you a few examples and case studies, and again, invite you for discussion. So hopefully you're going to challenge me on many things that I say today. It's not that I talk and you listen, it should be interactive. So hopefully you're going to get a discussion throughout or later after the presentation. All right. So I think just to put things in, I am engineer by background, but I've been working in commercial industries and business for 20 plus years. So my mind doesn't really work mathematics anymore. It works more in a business sense. So I look at the numbers from the very pure business angle. And when you look at the health industry, it's huge, right? So in terms of the manufactured revenue numbers or ICT market size, it's been growing fast. Compared to other industries, faster, right? So there are a number of these analyses which should show you that it seems there's a lot of investment there. But how does it get applied into the health system? That's a different challenge. I think what we are seeing, and if you go back to how the health systems have been configured, hundreds of years ago, we actually started with healthcare being very fragmented. So 300 years ago, the first healthcare was done in villages when there was a very smart person taking care of their village members, right? So they were mostly, I mean, art than science, but they were treating people in their own villages. Over time, when these people gain more knowledge, we put them into centers. So we try to centralize care so they can take care of more people rather than their own village. Well, now that resulted is in huge acute care centers. And that was fine when we needed to treat things like communicable diseases. And that's still happening in places like Africa or developing world, where the most of the burden comes from communicable diseases like TB, malaria, HIV, and so forth. And I mean, the reason why these centers have been built back 200 years ago was, unfortunately, to get these people inside of the center to provide what we know today as a palliative care, right? Mostly there was no treatment, but you would put them into the center so they don't spread the disease. Today, I mean, every 4 years, we get 1 year in addition in our life expectancy. And we are suffering more from the chronic care, which is not about being in a hospital. It's about continuity, right? It's about understanding me as an individual and my specifics about my chronic care, which may be the same diagnosis and anybody else in this room, but it's very different the way I'm being treated. I've met doctors which said, the way we understand care today, we would like to take some words out of our dictionary. One of the words is asthma. There's no asthma. There are like 50 or 100 conditions that we know under the word asthma, and they are all different. The way we treat them, the way we recognize them, the way we deal with these people, right? Diabetes too, the same. There are hundreds different types of diabetes too, really. So the way we should treat these conditions is not about putting them into the center. I mean, that's where it gets an acute care needed for somebody who needs longevity. I mean, there needs the continuity care. So it's about changing the way we interact with health system. And it has to be very personalized. It has to be very patient-centric. So instead of building more care centers, we need to understand that the way we deal with with care today needs to put patient in the center. The doctor doesn't have to be or should not be in the same room, in the same country, in the same continent even. And the way we encounter care is very fragmented. So we should be able to get the same level of care no matter where we are. And the ecosystem around us should be efficient, should be proactive enough to take care of us as the individual. So we now talk about reducing the money, if you will, that are being put into acute care centers to provide more remote care, more personalized service. It should be outcomes focused and value-based services, which is interesting, right? So most care facilities today, when you think about it, if they are working in a fee-for-service system, they will earn more money if they provide more service, which means if I'm a CFO of a hospital, I need to get more people into hospital, right? Because I get more money, which is different from what we need. We want to be outside of hospital the moment we probably come in, right? And that's about changing the paradigm. It's about values. So we will pay for the value rather than just the service. And data, turning data into actionable information is very important. We are also seeing a very interesting paradigm, and that's in the outline of the presentation. In many cases, we are outsourcing the data collection to the patient, and that's a shift that we've already done in some other industries. But in healthcare, they are now saying, and IDC came up with that prediction, that by 2020, 25% of the data that is associated with our care will be brought in by patients themselves. So it's bring your own data rather than bring your own device only, right? And it's amazing, it's like 25%. And I start to wonder what's gonna happen when we reach 50+%. Will the hospital need an EMR? Because more data will be in my pocket than in their EMR. So there's a lot of things changing there. But fundamentally, it's about getting the data into our pockets and making sure that we can share the data when needed, how needed, and for the purpose that it's needed. Just some other things, that I try not to repeat myself, but in terms of how we applied it today, it's interesting. This is from Harvard, and it was published recently, I think about 6 months ago. The way we applied IT in healthcare has made less impact than any other industry. I'm sorry, it's only education that has less impact in terms of the labor productivity growth, which is interesting. We put so much technology, but we still have a lot of labor. It's very labor intensive, so it doesn't really add up, right? Where it should be better in terms of how do we deal with that technology. One of the reasons is that most of the EMR systems are not really medical records. They are billing and reimbursement systems. And again, this is from Harvard, so it's not me really just referencing them, what they produced as a research. And this is, I mean, this is all what I already mentioned, but do read this. This is very interesting because it talks about AI, it talks about blockchain, a lot of things that was discussed throughout these 3 days. But I like this one. That was really a surprise to me, 25%. Again, that's compared to all the EMRs that your hospitals and doctors and GPs would have. That's quite an amazing number. So what I think we should be starting to talk about or to think about is how do we make sure that whatever data is collected in whatever ecosystem is collected is put into the center of a new ecosystem, if you will, where we feed into different environments that data when it's needed, and we provide let's say, the intelligence layer, so everything that is put around or the top feeds from that data. In the simplest terms, think about it, it's almost like your health profile on your Android or your iOS phone, right? So you have hundreds of applications on your phone. There may be other applications that doctors are using. Wouldn't it be really powerful if that profile could be natively sharing data, with your consent, of course, with all the AI systems or the blockchain systems or the EMR systems, and you always have the understanding of what is happening with it, and how do you make sure that you provide the consent and everything. So this is Gartner, and they talk about, instead of focusing on what they have here, on the lower right corner, the IT systems, it's about connecting things, customers and ecosystems into intelligence layer. And it can't work without the data. And that data has to be vendor neutral, it has to be open, it has to be clinically validated. Otherwise, you will not trust it. And that's the key message. So the challenge really is, if you would have the data, how do we go from the data to the application? And that's what we are trying to solve now. So now imagine, you are having this brilliant idea about the next diabetes app, but you are perhaps 2 patients who have been suffering from this disease for some time, and you see the problem, but you don't really have the IT skills. The investment, you are just 2 brilliant people, but somebody should invest into building the whole thing altogether. And how do you go to market and scale with it? I mean, I spoke to a researcher from Imperial College about a few months ago, and they done the analysis about the quality of the mobile health apps across the globe. And what they said that was amazing. The research came up to say that all these apps, and some of the reasons are on this slide, I mean, knowing IT, investment, the openness, the quality, they prove that the quality of these data, or this application, is far below any other industry, which is why people don't use it, right? It's pilots, it's ideas. But how do you go from an idea, securing the investment, knowing how to build the thing, and get to market and scale is not straightforward. In healthcare in particular, it's very complex. So it requires a lot of knowledge, a lot of cross-domain, cross-disciplines. And domain in particular is clinical domain. So I'm an engineer, right? And I was associated with a project back 15 years ago in my own country when we were designing the national e-health systems. And we got the requirements, and we were sitting around the table, and we designed all the diagrams. It was really powerful, beautiful, we thought. But then 10 years later, and it took us perhaps not 10 years, but 5 years plus, whatever, we realized that we've designed the system with not a single clinician in the room, right? So we got all these requirements. We were brilliant young minds from the university. We knew all the UMLs and mathematics and physics, everything, right? And we go through all the books about the use cases and the unified design and everything, and we build the system, and it works. The problem is that nobody knows how it works, right? So nobody knows what's happening under the hood. And if they need to change anything, they need to call us, and that's costly. And it's not costly because we want it to be costly. It's costly because we have to open up the hood and change things inside. Domain know-how was missing, right? We were getting the sets of requirements from the clinicians, but then when they went their own way, we went our way, and we really never came to the point that we can find a model where whatever they built as knowledge, it goes automatically as knowledge in our end. And regulation is difficult, and it's going to get more difficult, right? As we go into all these beautiful technologies. What about the patient consents? What about encryptions? What about the, is it a medical device or not? That's very, very difficult. So what we would like to do around this is to simplify the process. At the end, people want the solution, right? So they don't want to know what's happening under the hood. When you buy a car, you don't want to know what's happening inside. If you are a developer, if you are somebody who would like, a startup who wants to build something around AIs or whatever it is, you want the solution to be fast, efficient, sustainable, as cheap as possible. So we want, as individuals or as a provider, or as a startup, if you will, problem-solving application. That's it. It's as simple as that. So our idea is, what if we would provide you with the tools that could help you build an app perhaps without programming, tie into all the technologies that's been discussed throughout these days? What if we would help you get to the community of clinicians who are building clinical models, and these clinicians continuously improve on those models, so you tie to their work rather than replicate, and it's a continuous loop, and we help you with compliance and regulations. So with these tools, perhaps you can do audits, you can do consents and stuff like that. So our ingredient to the success would be that if you are an innovator and you have all these brilliant ideas, or some of these ideas, that from the idea to the execution, we provide you with the clinically validated content. So again, if you are building a diabetes app, let's say, that we provide you with the clinical models that are associated with that condition. It can be sometimes as simple as vital signs or certain very basic parameters of what you would observe about the person's body, but it can be very complex, like medication records and stuff like that, built by clinicians, right? So not by IT. So the second thing which we would like to provide you with is or we are providing you with, is the integration, right? And there's a lot of discussion, how do we get the data from one app to another, from an EMR system to your app, or whatever it is. That requires knowledge and long months or even years of learning, right? So if we would provide you with that functionality, you could have your application part of the ecosystem in different parts of the, I mean, again, economies or countries. And finally, regulatory compliance, right? So we would like to help with the making sure that your application is compliant on the lowest level to what it needs to be compliant with. These are tools, right? So basically, it would be somebody who is building the application to pick and choose whatever they think that is important for them. So that all should be in one place. So the idea, if you are this guy in the middle, the idea would be that if you have an application in mind, then in a matter of a couple of days, without programming, you can build a minimum viable product and show it to your investors and say, listen, I mean, this is my idea, this is how it could look like in 3 days or 5 days, whatever it is, would you be willing to help me? Would that be something that would be interesting for you? That's the idea. So a little bit about now technology, and I'll try to not make it very complex. So the way we do content, again being engineers, we are tied with an organization called OpenEHR. And if you go on openehr.org, you can learn more about it. The Open EHR is open community. Everybody's invited to collaborate. It's a platform for developing e-health systems, ecosystems apps. And the way it works is that is extremely important, and no other standard of technology does it. There's a very clear separation between what clinicians are doing in terms of defining the content and what the IT is doing in terms of building technology to take use or take advantage of that content. Everywhere else, it's all tied up together, and very fast and typically, engineers take over. That's all fine, they have their value, but I think the clinical part is very important. So the separation of these duties leads you to the point that people can model their knowledge without worrying what type of technology people use at the end. There are flexible modeling options, so you can build definitions of what they call archetypes, components like Lego blocks, definitions of the human body, and then use those Lego blocks into building a template, which is like a map. And that's a use case specific, like vital signs perhaps, or your form for questionnaire for diabetes, let's say. It's multilingual and it's reusable. To make it graphical, and I don't know how you can see this, it's another big screen, but this is an example of one of the oldest and most stable archetypes, and that's a blood pressure. And what you need to take from this screen is, first, it's graphical, so it doesn't tie to any technology. Second, the second thing that you should see is that blood pressure, all of a sudden, is more complex than just systolic and diastolic. So how can this be? I, as an engineer, would not, if I see this for the first time, I would not understand, right? The thing is that in healthcare, in different disciplines, you need far more, typically, than just systolic and diastolic. So if you're at your GP visit and you're doing your physical exam, systolic and diastolic 120/80 is fine. But if you are a cardiac patient and you are doing tests and you are sitting on a bike and doing under excursion and your blood pressure goes high, that does not mean potentially something wrong, because you are in that kind of an environment where these numbers should be different or would be different. So the whole idea is that the system should capture not just, or be able to capture, not just systolic and diastolic, but also things like the cuff size, the location, the method of taking, and things like that. So the idea then would be, if you would do this in different environments, that you can still share the data. So if you have, in one case, only taken systolic and diastolic, in another case, taken a lot more information, that you didn't build a different system, that they can still understand each other. And then, if you had these building blocks, then the next thing is how do you build the applications, right? And that makes it simple, because if you had all of this, and the community has about 700 of these, building things like GP visit form or a cardiologist encounter, you take these building blocks, you take out of the building blocks what you need, and build your form, which is part of your app. But fundamentally, on your health profile, it's built on the same infrastructure, clinical models infrastructure, which means that you can share the data. The data can be processed in the same way. So you know how things work under the hood, the simplest terms. What we do second, once you have this as a simple app, let's say, or a big app, if you will, like a new EMR system, the idea is that you have to collaborate with other systems, which may or may not be using the same technology. So what we've done, and this is a technical slide, a lot of components in terms of integration with existing EMRs. So think of it as if you need to get the data from your Cerner system or Epic system, the big ones in US and in many other geographies also, it should be possible that you get data feeds from them and into them. And we did a lot of technology around it to make sure that this can be integrated in between. I'm not going to go into details also in the interest of time, but I'm happy to answer any question. Oh, I'm missing a slide. But regulatory for us would mean providing not all the entire solution. That's not possible, because there will be different requirements in different cases. But what the technology should allow you is audit logs, for example, and that should come out of the box, so you always know who has access to your information and when, that you can provide the functions for consent recording, so making sure that people go through the process of authentication before they access, encryption at the communication level as well as on the data level and things like that. So it doesn't obviously solve the entire problem, but all of this together should lower your initial cost, and through the community you should be able, and also working with us, should be able to get support and training packages and market access, because all of this is global. The definition of the human body, which are these archetypes, is not specific to France or Croatia or wherever you guys come from. The blood pressure is a blood pressure, right? So in a nutshell, again, the whole idea from the patient perspective or somebody who is building an app should be, instead of going 6 months from an idea to, or a year, whatever it is, from an idea to the application, it should be days. And you should not go through the computer science course. You should not go through the medical course. You should be able to get to the minimum viable product in a matter of days, and then go deeper as you get feedback and you go through the process of developing. And we provide you with that. And it should be sustainable, meaning that if you have another idea, which is similar, perhaps another discipline, that all this content is reusable. So you say the message to the market that whatever you build is not tied to your technology, and it can share the knowledge that you accumulate in one application or the other. Few examples, and I'll try to be less marketing as possible. I mean, the community, it's not only us doing this, of course, and it shouldn't be. The community is globally present, and the strategy has been recognized by Gartner. So there's a Gartner report which talks about that integration, so integrating one system with another is not enough in healthcare. We need to be able to understand how the data persistence looks like, so things under the hood. And now being pushed across, obviously, other geographies. These are just some of the people that are using this aside of us. Our partners or part of the community by definition. And I mean, again, these are mostly Eurotransplant is in the Netherlands. There's a few of them in UK on this slide. Medtronic, medical devices companies as well, who are going into the areas of value-based care, and they need to compare the data from different geographies. It just doesn't work any other way. So let me dive into just two before I close. So this one I found exciting. This is from the developing part of the world in Philippines. Ayala Health is HMO, a health management organization, who are building retail clinics. They started from the pharmacies and now going into outpatient general practice. The problem in Philippines, there are many, but what they encountered was it's all out of the pocket, and it's very hard to have the continuity of care provided because they are the people, it's hard to identify them, it's hard to make sure that you can do a follow-up on them and so forth, and it's all out of pocket, so they pay 2 pesos, I think, for every encounter, which is really nothing. So what they've said, and they're going to build this chain of clinics, but they have to be able to provide first the solution for these doctors and nurses, but second, they be able to manage the data on the level of, not the application, but the persistence, the database, if you will, and make sure that they can do analytics, to understanding how can they improve. So they've used our technology, and they've used the community. They have a chief medical officer who is a part of the community, building content and so forth. And it took them 6 months to go live. From the idea, and having a couple of developers only, to go live, and that they are now live for about a year, and it's about 80 clinics running in different, shapes and formats. This, to me, is an evidence, right, that you can actually build such a thing in 6 months and grow and scale over time without problems of data migration, data collection, and so forth. This is the largest project that I'm aware of associated with this technology is Moscow City. This is big, and it's about 12 million people, 700 providers, 1 billion patient records, estimate at the moment. The challenge there was the mayor of Moscow and his team. They were struggling to engage into a project where the data that would be collected by the doctors, again, would not be tied to a vendor. They have massive problems with waiting lists. So, you have pretty much had to go on vacation if you had to see a doctor, because it would be hours of waiting, and then especially specialized care. So they needed to understand what is happening, and you can't do that without data. And they have now a control center. So if you go into mayor's office, there's a room with about 6, 7 big monitors. They know exactly what is happening in each of the doctor's office by being able to collect the data through the platform level. And the way they work, they have multiple partners. So they're given assignments to different companies. They said, somebody will do the prescribing system, somebody else will do the GP administration system, the third company is maybe doing lab system. And they were able to change providers because of low performance or financial, whatever it is, without losing a single bit of data, because the data is on the level of the content they can control. They understand what's happening under the hood. They've been live for about 3 years now. There's a lot of information that I can share offline. Contact me, as well, if you need more. And they are now going into the more difficult areas, things like task planning, pathways definition, and stuff like that. So let me conclude. I think there's a number of things which hopefully came across. I think by now we understand that healthcare is not easy. The innovation has been lagging. But I think fundamentally the reason is that we built the system for different types of needs, right? So the system what we have in acute care centers is not what the people actually need today. So we are probably spending a lot of time on overheads. There's a lot of studies around it as well, because we are not delivering what actually we as individuals may be needing. So the next generation healthcare has to be multidisciplinary, has to be putting us in the center and being empowered just to be able to be included in decision making and using the apps as we need in terms of our own personal needs and interests. The need to accelerate innovation is clear. However, it's not easy. I've seen, or when you've seen, all throughout these couple of days, fantastic technologies. But if these technologies cannot share the data and they build their own ecosystems, it's again not going to do us well, because my data will be all over the place, and providing continuity of care is going to be impossible. So the fundamental is the data. Once we solve that, everything else will be far easier. So the next generation of mobile health apps, and I'm thinking that the M will disappear. We will know nothing but mobile health, should decouple clinical record from the app. And that's the message I would like to leave you with. So think about whatever you are trying to build, that the content that your app is producing should not be developed only by IT and only by your team. Try to engage the community and get a content definition which is open source, if you will. Not in terms of the license of the technology, but open content, which would help you accelerate your innovation, but also tell to your customers that whatever you are doing, you are not tying them to any technology, so they understand how the data is collected. So I leave you with this. I thank you for your attention. Hopefully it was manageable with the time, and happy to answer questions.
Merci beaucoup Miroslav Koncha. Venez vous asseoir.